everybody. Thank you for joining us for working with LGBTQI2S youth for this month's Direct Connect with SAMHSA. So my name is Madeline Zielinski. I'm with Youth M.O.V.E. National in the Member Services Department, and I'm so excited to have you all here today. We are going to be talking about youth leaders in our community and examining sort of what it's like to work with LGBTQI2S youth within our programs and also sort of what that means. So we have a couple of presenters for you today. Like I said, my name is Madeline Zielinski. With us as well is Lydia. She is a youth program specialist with Youth M.O.V.E. National as well. And also Peter Gamache is our presenter, and I will let him introduce himself in just a second. But before we get started, I would just like to let everyone know that we do have a survey from SAMHSA that we would love it if you would go ahead and complete it for us after this webinar is over. We will put a link for you in the chat box. You will also have another opportunity when the webinar is over. As soon as it ends, you'll get, before you click out, it'll give you a little opportunity to click on that and give us some feedback about your experience today. And then also, if you decide to watch us on YouTube, there'll be a link there as well. So I'll go ahead and pass it over to Peter and let him introduce himself.
Thank you. Hi, everyone. It's great to connect. It's an honor to join you today. I contribute to SAMHSA in many different ways, serving on their national LGBTQI2S work group for youth and families, review funding applications for different initiatives such as their suicide prevention initiatives, and contribute technical assistance in other ways to really help systems of care to to advance their capacity. So in terms of our objectives, the outline of what we wanted to discuss today was really to run through demographic trends and the visibility of this population, the LGBTQI2S population of youth and young adults. And this is the big picture, as well as within systems of care, to talk about gaps in service systems that contribute to LGBTQI2S youth and young adult disparities, strategies for addressing LGBTQI2S youth and young adult disparities, and then all of this information is applicable to SAMHSA's system of care grantees in particular, as well as any jurisdiction or organization that really wants to address disparities among this population. So when we take the big picture and we start looking at the overall focus on what are we talking about in terms of the numbers around this population, there are different estimates and studies, but the ones that we really look at, the broadly nationally representative research and data show that about 3.5% in one study, for example, of U.S. adults identify as LGBT and 0.3% identify as transgender. It's estimated that there's more than 2 million who are ages 10 to 24 who are within this population. There are same-sex couples that live in every state and in 93% of all counties across the United States. 21% of same-sex couples are interracial or interethnic, so there are intersectionalities among this population. And approximately 2 million children live with LGBTQI2S parents. So this is definitely a timely and a relevant needed discussion point to really think about how we look at the data, how that can inform services to be improved and continually enhanced. And here when we start talking about data and we start talking about how people are identified, we have to kind of think about some acronyms or terms or definitions, because people have to ultimately there has to be a data point. There has to be a sort of circle the answer or a check the box or a disclosure or acknowledgement of some kind where there's an identity that would fit, what would be looked at in terms of a data category. So overall, when we look at these definitions, we know that there are evolving ways that they're described. Within SAMHSA's publication, for example, as depicted here on the right, Ending Conversion Therapy, Supporting and Affirming LGBTQ Youth, there's a discussion around the differences with sexual orientation and gender and how those are defined So sexual orientation is this really multidimensional construct, right? It means it's complicated. It's got a lot of components to it, and it can involve sexual identity. And this is someone, again, circling the answer or checking the box, that kind of thing. There's sexual and romantic attraction, where there's an attraction that's expressed toward same-sex, relationships, for example, as well as sexual behavior. So we know that there are people who are engaging in same-sex sexual behavior, but they would never identify or check a box, right, or say, yes, I'm, LGBTQI2S. So we have to really keep those things in mind when we look at data overall and those percentages that were just mentioned previously, and that those can really be an underrepresentation because not everyone is going to, sort of disclose, their identity in that way. And then gender is a ubiquitous and multifaceted social category. It's a social construct, and this is a concept that is where scientists are basically trying to distinguish between biological sex, and so this is an anatomical determination, gender identity is someone's self-expression of their gender, and then their gender expression, right, how they outwardly present themselves in terms of gender. And this, as we know, has evolved considerably over time, everything from the length of someone's hair to wearing makeup or wearing certain clothing styles, right? Does that mean it's male or does that mean that's female? So these types of things have definitely changed over time when we talk about these kind of concepts. And there's ongoing dialogue, right, among different groups. There's policy organizations, advocacy organizations, local communities, rural versus urban, for example, communities. There are national work groups, professional societies, right, and individuals even who really are having this ongoing dialogue about the best ways to describe this population. So it's very interesting, and different terms are coming up. For example, should we include the word queer, right, on surveys? And so some might say, oh yes, well that's a positive term because youth are really reifying they're taking that term and making it their own, and as an empowerment, as a positive way of expressing themselves. And then others would say, oh no, if I hear the word queer, it's sort of a trigger for me. It's going to make me fearful. It's a negative term, right, of how they've experienced it in their lives. So sometimes there's this discussion, right, about whether or not there should be different words or terms included. And these symbols that are listed here are examples of different symbols that have been used within the LGBTQI2S community. There's the lambda, and then there's the question mark and rainbow, and there's the onks, the female symbols intertwined together, and other types of symbols, the pink triangle, and the triangles crossing over, right, and different things that have been represented. But these even the symbols are also evolving. So it's very interesting to how this rainbow community is is moving forward. And there are different trends when we look at demographics. There's data that we look at, like from the U.S. Census, for example, as well as changes in visibility. Just within the last 10, 20, 30 years, there's been different levels of visibility in popular media and in people's consciousness and family dynamics and discussions. So visibility has definitely changed over time. And when we look at the data and we see all these diverse changes happening, it really leads us to really say, well, okay, if we know that there's an increasingly diverse population, right, among this community within the United States, then we need to look at the disparities that they're experiencing. So an increasingly diverse population leads to an increasing need to address behavioral health disparities, because organizations really need to address the needs of the communities that they're serving. And sometimes, without proactively collecting data, there may be a lagging effect where, right, there's a sort of responsiveness that's down the line rather than being kind of cutting edge or right on the the current state of knowing what's happening in different communities. And I just wanted to note, too, that the U.S. Census has also evolved over time. The first one was way back when the country was new, and that was the year 1790. That was the first U.S. Census. The census is required by the U.S. Constitution, and those categories, as you can imagine, have changed very dramatically over time. You can definitely look up, how those early categories were, and they are very interesting because they were not certainly as diverse as they are today. And even in our recent history, in the year 2000, the U.S. Census started collecting multiracial data, where people could indicate, for example, that there were more than one race. And so now we have this wonderful data that shows, oh, now people are self-identifying as multiracial, and then we can look at changes over time as the census data are collected every 10 years. And in the year 2010, that was the first time that we had same-sex households data. So that was a really monumental shift in how the understanding of this population has been evolving. And just to note, there's certainly no one look or type of family. Family dynamics and structures have been evolving over time. There's the two male caregivers with a child. There's two female caregivers with a child, and there can be opposite sex arrangements where there can be a biological child that's conceived. There's single household families, and all kinds of different blended and extended family relationships. So among this LGBTQI2S community, when you look at family, how families are set up, it can be very, very different than what can be kind of understood in an automatic way sometimes. And here are some great pictures of families and how they look, and I just love these pictures because they show this really celebration. There's a wonderful picture in the lower left-hand corner of two ladies who had waited so many years for having their marriage recognized, their relationship recognized, and they're celebrating. There are families that are interracial and interethnic, and there's just amazing diversity among the LGBTQI2S community of how families are structured. And really this shows the supports that they have as well, the diversity of different communities, different types of communities that are surrounding this population, and helping them as they can. So one major source of data is the Williams Institute. Definitely want to highlight their great work. They crunched the data basically from the U.S. Census in the 2000 U.S. Census data on same-sex households and same-sex households raising children. And they have a great website. You can look them up and pull down state level or county level maps, for example. And so sometimes you might hear in your community or your agency, oh, well, we don't have those types of people, right, that live around here, or we don't have those types of clients. Well, you can access the Williams Institute maps and show that certainly there are people who are living in the area. And I'm going to show a few of these in just a few moments. But, that's one way of sort of objectively presenting the case for, the need to address the needs of this community. And so here's an example of a nice map that they created of the entire United States. And this is same-sex couples per 1,000 households. So this was one sort of standardized way to look at density of this population across the United States. And you can see that there are some lighter areas, there's some darker areas, maybe where there are areas that were not expected or that were. And even within some of the lighter areas, if you were to zoom in, right, into some of these states, you might find that there's a dark spot or a dark area density, detection of many people who are within even an area with a lower level overall at a national level. And the percent of same-sex couples raising their own children is even more dense. I mean, you can see that it's really scattered all over. And so this presents a really nice way to, to recognize that there are these populations within your own communities. And it's even in some areas where you may not expect, or maybe you would expect, to have same-sex parents raising their own children. This is one way to do that. So, for example, in Mississippi, there was a report, and shortly after the 2010 census, and this is in 2011, reported that Mississippi leads the nation in the percentage of same-sex parents. So that was an interesting finding that came through from looking at the data, and so then agencies all across Mississippi were made aware of this information, and to incorporate this into their youth family planning groups, their advisory and oversight councils, their community discussions and their meetings. Right, so they could then say, oh wow, are we addressing the needs of this population, or are there ways that we can do things in even better ways than we are now? And so this is just a quick kind of rundown of how the process can be, because it can always be improved, and so that's always the sort of point of discussion for continuous quality improvement. So in the 2000 survey, U.S. Census survey, the person filling out the form, right, person one, who they describe, is asked to identify how all other individuals in the household are related to them. And then if they were married or they were spouses, they had the option to indicate husband or wife. Okay, so then people who were unmarried partners, they could then indicate that they were in a close personal relationship. Okay, so that then begs the question, well, okay, what does that mean for some people who are they sort of checking the box on LGBTQI2S? No, not necessarily. Are they being asked about their attraction, right, or behaviors, or so all these other dimensions that we discussed earlier. So that's kind of not what they're getting to. They're really getting to this close personal relationship, and there's ways that the U.S. Census is even improving this process even further. There are trends that are contributing to this evolving demographic data and awareness of this population. In 2015, there was a major U.S. Supreme Court case of Obergefell versus Hodges, and this was the one that declared that same-sex marriage was legal across the United States. And Justice Kennedy said that they asked for equal dignity in the eyes of the law, so that the dignity that was hooked into the constitutional rights that are granted was the primary rationale. And the lead plaintiff, Jim Obergefell, said, the very words that are etched on the front of the Supreme Court, equal justice under the law, applies to them too, right, to same-sex marriage, people who are in same-sex marriages. So this is really a very landmark case that contributed to this evolving trend of awareness and starting to collect data around this as well. The U.S. Census Bureau I mentioned is evolving. They revised the relationship question. They've worked with the internal federal agency work groups. They've added additional categories. They've sought to reduce reporting error. Right? So these are the types of things that they're working on. And they are going to collect data through one specific survey called the Census Barriers, Attitudes, and Motivators Surveys. And that's designed to better understand the mindsets related to census participation across demographic subgroups, including the LGBT population. And then that question on sexual orientation is planned for the next U.S. Census. And there's also data around, how families are accepting or rejecting young adults, LGBT young adults. And there's been a comparison. So Caitlin Ryan did some amazing work, literally putting numbers to these concepts and asking people these questions and collecting data to compare for those families that have greater levels of acceptance versus lower levels of acceptance or rejection, and found that when compared with their peers from families that reported no or low levels of family rejection, that these youth and young adults were 8.4 times more likely to have attempted suicide if they were from families that highly rejected their sexual orientation during their adolescence. And that's pretty striking. Those are striking numbers. They were 5.9 times more likely to report high levels of depression, 3.4 times more likely to use illegal drugs, and also 3.4 times more likely to report unprotected sexual intercourse, and that then creates other challenges as well, such as risk for HIV and STDs. So family acceptance, the relationship, and that being a really important component of how service agencies need to really address the needs of this population. It shows how important family acceptance is in that process. And so definitely on the local level, especially within systems of care, the ask is always, to update those forms, to collect inclusive data. There are requirements for collecting this data. This is not sort of an optional component, and I'm going to discuss that in just a few moments. But really, if agencies are funded by SAMHSA to operate systems of care, or there's different other types of agency requirements depending on where agencies are or organizations are structured, that may or may not specifically require the collection of LGBTQI2S data. We should really have a standard way to collect this and to understand this population. And what we know is that people who are transgender in particular, they often don't exist at all on any agency organization's forums, like intake forums, for example, or satisfaction surveys, any other records like a training evaluation, or things that they're involved in, right? So there's no way to indicate, right, their identity for their sexual orientation or gender, and so when you might have a demographic form, for example, that has age and race and ethnicity and all kinds of different questions, frequently we'll find that this population is left out. And so one example that's provided here, there might be a sort of checkbox or a circle area, right, where there's just male and female. And so there needs to be additional options that are provided. And if we look at how those questions can be asked, one option is to adapt or use this work group called the Gender Identity and U.S. Surveillance, the GENIUS work group's best practices for gender identity. And this is called the two-step question, is to ask, what sex were you assigned at birth on your original birth certificate, right, male or female, and then how do you describe your gender identity? And there's male and female, as well as male to female transgender, female to male transgender, or another gender identity. So this provides those additional options to understand, this population. And in terms of improving access, right, you want to make people feel comfortable, right? You don't just kind of drop a survey cold on somebody, or, here, fill out these forms, or, just kind of like ask these questions that might be surprising. You want to have welcoming environments. You want to make sure that there's an understanding around the purpose of the data collection, right? Please help us understand the diversity of people that we're serving. We want to try to improve services, so it's really important for us to have this information, right? And that's the way to kind of frame it, or to present it in a way that's welcoming and really is helpful, and that's the whole reason. And so there are other examples of ways to to make people feel welcome. One easy thing that can be done is to use preferred pronouns for example, at the front door. There can be sort of stickers or buttons I've seen where somebody can literally write in what they want to be called, right, while they're there visiting. And it's right at the front desk or the front, the front area, right when they walk in. And so that's one way that agencies have really taken a proactive approach to providing people with that option. And there are ways that agency staff can signal that they are aware of this population and, the ways that pronouns are used. For example, Kimber and Robin, my wonderful colleagues, they have in their email signature lines, right, their preferred pronouns. And so that can kind of signal, how their agency is specifically welcoming. In terms of sexual orientation data, there's the National Survey on Drug Use and Health. That's a SAMHSA survey. It's a national survey. And they address sexual orientation in the following way. They ask people, which one of the following do you consider yourself to be? Right? So it's allowing people to self-identify. And it says heterosexual, that is straight, or if it's a female respondent, they could say lesbian or gay. If it's a male respondent, they could say gay or bisexual, right? And so these are the ways that this survey has moved forward to really understand the needs of this population. And there's many examples of welcoming signs and symbols that can be displayed, safe zones or safe spaces for this population, and as well as other populations of youth and young adults, is to really make people feel comfortable, right? It's to assure people that it's a safe place, right, for them. And so there can be signs, for example, on building entrances, meeting rooms, common areas such as the waiting room, or maybe it's the conference room, or the the youth drop-in room, or whatever the the sort of setup of where people are gathering. There can be a sign display, and there's different examples. There's rainbows and there's triangles and safe zone messaging that's there. Or if your agency says, oh, we're kind of just into the sort of blank signs. We don't want to have images or whatever the reasons why. There can just be a sign that says this is a safe zone, and this is on the upper right-hand corner here, and it says this space respects all aspects of people, including race, ethnicity, gender expression, sexual orientation, socioeconomic background, age, religion, and ability. I mean, that really is a safe place. It's a place that I would want to be, right? Because it's showing how inclusive and welcoming it is to all kinds of different types of people. And here's just some more examples. There's colorful things that are available. You can look up Safe Zone online, and there's lots of different options. Here's an example of a picture that I took of a sign that was posted right in the glass window of right next to the entrance way, and it says Safe Zone. With that language that I just read, with the pink triangle and the green around it, meaning this is okay here and welcome here. It was also translated into Spanish, so there's a Spanish version, Spanish language version. And so these are just examples of ways that things can be shown. And I've also seen where individual personnel, maybe they'll have the rainbow sticker on their office door, or maybe they haven't really gotten the acceptance to put it in signs in a way that are posted in their agency and in common areas. So for themselves, they can symbolize that they're an ally and are supportive. And so this is an example of a therapist who put this in her office right when people walk in, so they know that they're welcome. And so these are just types of examples. Or maybe it's the folder, right, of when you go to meet with somebody, and they can see right on top of the folder, or on the back of it, or on the computer, or wherever, the sort of materials that you're using to have something that symbolizes, right, that you're an ally or you're welcoming. And so that can have a major effect on how people can be made to feel comfortable. There's lots of gaps within service systems. Just to point this out, that there's systematic gaps, right, that are contributing to youth and young adult disparities who are LGBTQI2S. Some are, let's say, more attuned to the needs of this population compared to others in the child system and in the adult system. And we really want to have a big picture perspective on how systems of care can work together for the needs of the populations they're serving. And some of the things that you can run into as well are certainly negative attitudes in or surrounding service systems that are contributing to disparities among this population. This is called the Riddle Scale, which is a really useful way to show how people have different reactions to addressing the needs of this population, all the way starting from on the very left-hand side of denial, where people will say, nope, these people don't exist here, this is not an issue, it's not needed, it's whatever, it's denial. So that can be where people are starting from. And then they can acknowledge that people exist, right? So that's beyond denial. We're moving into numbers 2+ now, but they may have really negative reactions to this population for whatever reason. Maybe it's personal or whatever, repulsion or pity, right? Real negative. And then they can move to tolerance and a kind of live and let live approach to this population. And then onward to more positive aspects of acceptance and support and admiring for example, the contributions that are provided from this community, this diverse community, appreciating them, and then nurturing and celebrating, right? So really supporting this population. And this shows that people don't kind of move like a light switch overnight, right? From denial to celebration, right? You don't just jump from 1 to 10. There's a staging of this. So this is just a way to kind of conceptualize the different ranges of reactions to this population. And negative attitudes can come in the form of, certainly family rejection and bias and harassment and all kinds of negatives. But there's a piling on effect as well with other types of things that are causing disparities among this population. There's unequal legal protections. There's health and behavioral health needs and challenges that are not being addressed. There's historical trauma and discrimination, experienced by this population. When people hear, that there's targeting of this community, for example, in Orlando, Florida, we had a nightclub, right, where this population was targeted. There's people who are beaten up or bullied, right, and that's reported. And so that can have a chilling effect of how people are afraid to identify, right, to live openly and to really seek care sometimes when they need it. And so the ways that we can counter some of these effects is number one is always knowing that they exist, right? We have to move out of that denial stage. We need to collect data and really just understand more about what's going on and how people can be best helped. And there's support for this. I definitely wanted to point out that addressing disparities is increasingly expected and required by different funding agencies. So there's an administrative reason for this, monetary, and it's not just the right thing to do, but it's also about supporting how systems need to operate. SAMHSA, for example, the Substance Abuse and Mental Health Services Administration, they have different initiatives that they fund systems of care, and they also have other initiatives such as the Targeted Capacity Expansion HIV program, Offender Reentry program, and grants for the benefit of homeless individuals, services and supportive housing programs. And each one of these is tuned to, looking at disparities. And for example, whenever someone goes to apply for one of these grants, there's a section A that talks about the population of focus and the statement of need. So the proposer needs to really describe the catchment area, what's the region that would be served by the project that would be funded, and then how does that population look, right? What does the community look like in terms of their race, their ethnicity, federally recognized tribe, their language, their gender, age, socioeconomic status, right? And so a lot of these things can be gained from the U.S. Census, right? So that these can be looked up and create a nice table. And then there's sexual identity and sexual orientation and gender identity. And so that's where the Williams Institute data that I mentioned can be used. as well as any local, right, collection of data. So agencies or organizations that are really on the cutting edge, and they just do this, right? They collect surveys, they understand their populations, they've got reports that they can draw from, they're ready to go. They're ready to, to sort of, they're primed for the next, for the expansion of services and the enhancement of services through funding. And so those agencies that don't have these types of data available, well, they're not really, in comparison, they're not as prepared. And federally, this is definitely supported at the federal level. U.S. Department of Health and Human Services has its action plan to reduce racial and ethnic health disparities. So these are the types of policy documents that are out there that the grants and the funding of these federal sources are hooked into. And so agencies that are funded to operate projects that are funded from the federal government, they are definitely required to adhere to, right, these types of things, right, by accepting those funds. And there's this secretarial priority in the action plan that says that they will assess and heighten the impact of all HHS policies, programs, processes, and resource decisions to reduce health disparities, right? So that this is the tuning of the use of funding and resources to address the needs of diverse populations. This is an intentional, support to address disparities among populations. So I just wanted to definitely point that out, as something that is moving this forward. And agencies, for example, this is just one example about agencies when they receive their notice of grant award, right? Congratulations, you've been funded to operate this project that you had proposed, to address needs of people, substance abuse, mental health needs of people. And by accepting these funds now, here are the sort of terms and conditions of the award. And one of the terms and conditions is to submit a behavioral health disparities impact statement, right? That's a long term for, what is being produced, but I just want to repeat that it's the behavioral health disparities impact statement. And so the agencies need to create an impact statement to outline, right, how they're going to address disparities. So it's basically kind of like a mini work plan or sort of like a description of their intent to address things within the project. And so the section A is to talk about those populations of focus, similar to what I just mentioned in terms of section A of a grant proposal. They're going to, definitely fold that in and say, okay, we know our populations, right? And here's the table, and here's the description of who we're going to be serving, all these different types of populations, diverse people. And then section B is a statement, their data collection, right? Their data reporting, for example, right? So this is not sort of nice to do or optional. This is kind of a day one, so sometimes, I'll hear that organizations will say, well, we're thinking of including LGBT into our surveys or starting to collect data, and we're having discussions around it. And that's great. That is wonderful. That's something to be celebrated and supported. And it's also something to point out that, well, really this was something from day one. So just to kind of point that out. And then section C is the plan for adhering to these national standards, right, class standards, and they stands for the linguistically appropriate service. And they've basically, in a boiled down way, and to describe it, they are addressing diverse cultural health beliefs and practices, the preferred languages of different populations that are being served, as well as their health literacy and other communication needs that they might have. So this behavioral health disparities impact statement has some sections to it, right, that need to be filled out and completed and described to really outline how an organization is going to address the needs of diverse populations. And that's the whole intent of this. It's all about quality improvement. It's not sort of a negative or a, something that's going to be, anything negative around it. It's really to improve diversity of services and access to the services. And so in terms of addressing disparities, it's also supported by systems of care, values, and principles. And this adheres to family-driven and youth-guided services, community-based services, culturally and linguistically competent services, and data-informed services. Right? These are core values of systems of care. And so this is yet another layer of support for addressing disparities among the LGBTQI2S population. So in terms of, that's the background, right? That's the need, and that's the sort of all the different layers of the rationales why it's important. So now when we look forward into the how-to, the question is, well, what do we do, right? What are the types of steps we can take for addressing disparities in a constructive way? Well, number one thing is to update those forms, right, to collect inclusive data. And there's lots of examples. I showed you one set of examples, and there are definitely things that are out there, that questions that can show how updates can be made to those forms. And this includes like paper forms or an electronic, right, or tablet, or whatever format of where data are collected, where there are demographic questions, for example, about race, ethnicity, and gender, and age and other things. Well, LGBTQI2S population, is part of that as well, but they aren't left out. And then also to expand safe zones or safe spaces for all youth, right? And this includes receiving safe zone training that might be available from a local organization or a university or another provider of safe zone training, if that's available. To designate safe zone, or even online, there are also online resources, to designate safe zone areas, right? As I mentioned, meeting rooms or common areas, to really show that it's a welcoming place, to support individual personnel who self-identify as allies, right? So maybe they're not LGBTQI2S themselves, but they're an ally to this population, and so they need to feel supported and safe to be able to do that. And in line with them being supported, really looking at anti-discrimination policies, right? Are the employment policies, for example, inclusive? That says we will not discriminate on the basis of, right? And it will say race, gender, right, et cetera. So is LGBTQI2S included as part of non-discrimination in the employment policy? And again, this is not just for people who are LGBTQI2S, it's also their allies, right? People who are supporting them. To look at partner agencies. So for example, one organization, let's say it's a mental health organization, may be very welcoming and very inclusive, and showing this within their organization, but they might provide a referral, or there might be a provider in their community that is providing housing, for example, or maybe it's another organization like the school system or the juvenile justice system or child welfare or foster care system, right? So it can be another system that is in their community, but that they are not as welcoming, right? Or they need to have some supports, shall we say, for advancing their inclusion and their welcoming environments. So maybe looking at their policies as well. If you're having inter-organizational work groups, right, making an agenda item, like can we look at our our policies together, because we really want to make sure that youth are going to be supported no matter where they go, right, in this large social service system that we have. And then looking at vendor contracts, for example, organizations will have suppliers of some kind, physical supplies or other types of supports, information supports, or other types of contractors. So in those contracts, is there non-discrimination as well, right? So that can be a consideration. And then there's a whole litany of different things, right? So these are just sort of a list of options, and you don't have to have all the answers. If you work with the youth and the families in the services and get their recommendations as a direct feedback loop to inform the quality of services that are being provided in a continual way, then you're going to get to these types of items. And this is a list of things that have been collected over time based on interviews and focus groups and surveys, and so these are just common ones, but certainly in your local community, they're the experts on helping you to, to come up with strategies. You don't have to have all the answers like tomorrow, that kind of thing. And so other items include identifying training opportunities on selected topics related to LGBTQI2S disparities. So for example, it might be homeless youth, right, who are part of this population, or suicide prevention, right, among this population, or the bullying that people experience when they're part of this population. Right? These are specific topics that can be provided, and there can be training to really update people on understanding the needs of this population. Sharing the learning content within the larger system of care, right? So maybe it's the foster care families that need to know more about this, or the schools or the faith-based organizations in your local area, right, to share that learning content with them, to develop inclusive referrals for youth and families, to partner with community alliances, right? Maybe it's other organizations that can come in and do a training, or they can come in and provide expert consultation, to also have local inclusive success stories. And this is something we're always looking for. How are people describing the successes of how services are helping them? And so how can we show that by being welcoming and having a welcoming environment and doing all these different steps that were just described, what was the impact, right? How did people describe how that made them feel when they came in to receive services? A success story is really the way to describe that, the richness of that experience, as well as self-assessment tools for agency or program staff. So there may be some staff, right, that have some needs around addressing their biases, or there can be preconceptions or even just misunderstandings around this population, right? So maybe a self-assessment tool agency-wide needs to kind of cast the blanket out to say, where are we on this? Is everybody comfortable? Is everybody kind of aware of the needs of this population? Is there discomfort? Is there rejection, or is there stigma, right? So there can be that open dialogue around understanding what can be done. And then other longer-term types of things that have been raised include asset mapping, and this is connecting with local, state, and national resources, right? And this can be supportive in organizational ways, like letters of support, or memoranda of understanding, or support funding proposals, or working together and linking and partnering on projects. So that's a great way to do asset mapping. To do diversity or climate surveys in the community, to identify safe space resource champions, right? Maybe it's a trainer, somebody who can go and get a training on becoming a trainer for the local community. That's one way to to really kind of pass things forward. And then having local learning events for those the sort of train the trainer resources, connecting with other systems of care, right? Finding how there are models or examples of things that have been challenges that have been overcome, and how there have been successes. I've worked with many communities that there were lots of needs, right? And they've come like light years from where they were, in terms of addressing things, in certain ways that are, signify, that they're really doing the best that they possibly can. And so there's success stories that are out there in terms of service models, and there's examples of how challenges have been overcome. Whether it's we don't want to do that type of survey, or we don't want to ask these questions, or whatever, that type of thing. There are ways that you can get the feedback of youth and families on how to best do that. And then there's social marketing activities. Social marketing is about changing voluntary behavior. right? So you're not trying to change people's minds. You're trying to change their behavior. So there may be people who, for example, have some type of bias, right, among youth and who are LGBTQI2S for whatever reason, their whatever beliefs they might have, and it's not their beliefs that need to be changed in terms of interacting or engaging with this population. It's their behaviors. So maybe they don't they need to not say things right in an open meeting or act a certain way that can be stigmatizing because that can be very negative for the the population that's being served. So there's an approach to this to making it so that everybody needs to work together and really support one another. And so that's the sort of components of the major aspects that we wanted to cover. And here's our contact information for follow-up questions or any resources we can provide. We're definitely here for you to support the initiatives or anything that you want to do and have questions about or supports for. And so now I'll hand it back to Youth M.O.V.E. and we'll open up our discussion. Thank you.
Awesome. Thank you so much. So we are going to take some time now if we could just open up to you guys for questions. So if you would like, you can go ahead and post questions in the chat box for us, and we will just go ahead and moderate them from there. So thanks again, Peter. It looks like we're getting a lot of appreciation for you in the chat box. And again, thanks everyone for joining us. So we would love to hear your thoughts and questions. If you have any experiences you wanted to lend or areas that you had questions about, please feel free to just insert them there in the public chat box. Looks like we have some people typing, so we'll give it just a second.
Well, while people are typing, I just wanted to mention that sometimes the timing of things can be moved around. The how part of collecting data, asking questions, that can be just depending on what your local operational needs are. For example, I've heard, well, we don't want to ask those questions of youth when their parents are in the room because we might be outing them, right, inadvertently and creating a negative, right? We want to avoid that. And so if there's a concern like that, then maybe there's this sort of when things are asked is different. Maybe it's how things are approached, right? There's a sort of pre-discussion, right, with the youth and the families about questions and, the purpose of them. There's just lots of different aspects of, when people are saying, well, we can't ask those questions because, right, and they'll say, well, people will feel uncomfortable or, whatever the reason is, or maybe it's intrusive, right? I've heard that. It's a common thing. But then it's amazing because when you say, okay, well, what types of other questions are you asking them? And they're asking about all these mental health, substance abuse questions, right? All very personal and, like very, intimate questions. But then it's like, well, why can you ask people about their mental health or their drug use or whatever, but then you're uncomfortable asking about sexual orientation or gender? Like, where's the connection point on this? Or maybe it's, how things are asked is the consideration, where it's like, well, if there's a projection of, well, they would feel uncomfortable, okay, then it's like you ask the question, well, how do you know, and then you come to find out that there can be examples of where it's not the youth or the families that would feel uncomfortable, it's really the staff, right? So they're just kind of saying that they don't want to ask the question because they think that people would feel uncomfortable, but it's really them. So, these are the types of dynamics where you have to kind of explore, like, what's the root of, this, and how can we make improvements? And it's really all about the needs of youth and families. And if the needs aren't driving every process and step and, activity of what's being done, then, it's just not connected in the right way. So always having that feedback loop from them. And I found that youth and families will certainly, they will talk, many will express all kinds of information, right? It's just a matter of how things are presented and how that exchange goes.
Yeah, that's really, really valuable information. Thank you so much for sharing that, Peter. So yeah, discomfort is a big part of this. And so we would love to just remind you guys that this is definitely a safe space to ask questions that might be uncomfortable, that we are here. Lydia and I both have experience as LGBTQ advocates working in our own communities. And so this is a really important subject to us. So we're happy to answer any questions you have, no matter how awkward they are. So we have a question in the chat box. It says, how would you approach the question when you are in the clinical setting? Which I think is something that Peter touched on. Is there anything else you want to add about that?
The clinic setting, this is like a medical setting? Is that right? Yeah, okay.
Yeah,
so
it was in
yeah.
primary clinical setting.
Okay. Yeah, so similar to, it's kind of like when people are asked different questions like health histories and all kinds of, things that can help to paint the picture of what someone's life is like and how that impacts their health, I think that that's part of the dynamic. And so sometimes, there can be a sort of belief that, well, people don't want to say stuff like that or talk about that because it's really just not part of their, what they're there because they have some type of medical, related thing, and that's really the narrow sort of aspect of what's going on with them. But just like when you go to a doctor, for example, or a practitioner, and you don't disclose certain things, about your health or whatever details, that is definitely part of some of the challenges in medicine of not having those open conversations. And so a doctor might not be, or a practitioner would not be able to treat or address the needs, in a holistic way. A therapist, for example, would, not know, for example, if your challenge is depression or anxiety or, whatever other types of thing you're experiencing, it may certainly be related to trauma or other types of, challenges that have been related to your LGBTQI2S identity or expression, right? So without talking about it, then you're not really kind of addressing the, what there is, what is the sort of core of this, what's unearthed underneath this, the anxiety or the depression or whatever it is. So it's part of the dialogue. It's part of, understanding what's going on with people and how, this impacts their health. And there's many different examples I can provide. I've had friends, for example, same-sex couple who, they went into a hospital setting and, they were sort of avoiding. They were saying, one was saying, oh, I'm the friend of this person. Well, they've been together 46 years. So, friend is, when I heard that, I said, wow, that's really surprising that you said that. Like, why? Well, because I don't want him to be discriminated against, right? Or somebody to treat him badly, because there's this vulnerability. And so that's really kind of a shame, right? That's something that can impact, that relationship, that therapeutic relationship, and really the providers even understanding who is there as the primary support person. It's that's the sort of level of their relationship is not just friend, right? So that's one example. There's many other examples of sort of, not of making assumptions about, people's health related to if they're perceived as not being LGBTQI2S, right? Maybe they're not going to ask questions, right, about health histories or other things that would, be relative to, being able to address their needs. So I think this is an important point because there's so much that's missed Practitioners and clinicians, they need to have a holistic picture, have the information, to be able to have that dialogue, and they need to provide an accurate diagnosis and treatment plan in partnership with the patients or consumers or clients. And so by not having gaps or holes in the information, well, then there's higher risk or likelihood that there's going to be a challenge of not addressing their needs. So I do think it's really important to have that open dialogue and make it a standard practice, right? It's not sort of the weird question. It's not like, oh, and by the way, are you, LGBT or QI, or QI, just kind of pop that on somebody. Just kind of make it part of the regular standard of care. For example, if there's any demographic information, that's where to do it. Can we get, we need to fill out some information, or we need to, better understand your needs. Please help us understand the diversity of the clients we're serving. What is your age? Okay. How do you identify your race? How do you identify your ethnicity? How do you identify your sexual orientation? How do you identify your gender? See what I mean? It's sort of like a normal thing, not something weird or set aside. And so that's part of kind of, just normalizing and having it part of the way of doing business, really. So I think that's
absolutely.
The best way.
Yeah, thank you so much, Peter. I think that you really hit a great point in that if you can kind of ask for that demographic information in a series of questions that just feels very normal, then it's going to make the person that you're asking feel like it's very normal for them to be able to disclose that information for you and add that level of comfort. So thank you for pointing that out. So we have another comment in our public chat from Barbara. She says, this is very informative. I appreciate your time. My suggestion would be to change the language around same-sex and opposite sex in the future. Our youth does not usually use this language, and I think we should be keeping that in mind when we work with youth. She says that opposite sex reinforces the binary, and we want to stay away from that. So thank you so much, Barbara, for bringing that up. And that reminds me of something that I learned recently in my advocacy work, that people are starting to also stop using the term homosexual. And I thought that was very interesting, and I don't totally understand the logic, but Lydia has some information. So Lydia, could you speak to us a little bit about why we don't want to use the term homosexual in the clinical setting?
Absolutely. I think part of it is certainly, as Barbara said, that's not language, especially with young people, youth, young adults are using to describe themselves, and so it may feel discordant or not like it doesn't fit the setting. If we're talking to youth and young adults, let's use that language. But secondly, I think it's also an effort to sort of declinicalize LGBT identities. And so if we're always using words that sound very clinical, that sound very kind of a heavy history in being pathologized, that's going to kind of stick around. And so moving into how people identify versus words that were used when it was considered an abnormality or considered a bad thing about someone in illness is, a more strengths-based way to talk to people about them and their experiences.
Yeah, and absolutely, and I even, I find myself needing to reflect on terms and definitions, and again, these types of things are ongoing, but I think that's a really critical point and really important one. And the reason that I kind of use that term is really because it's the data part of it too, and that's, again, it shows the limitations of surveys and data, like the U.S. Census is same-sex, right, households. Well, that's limiting. So in a way that it was better than what it was, which was nothing, right, before that the 2010 survey came out. But then now we're moving to the next evolution where these conversations, these dialogue points are moving forward to help to even better refine the ways that questions are asked. So thank you so much for raising that.
Yeah, absolutely.
Question from, oh, go ahead. Sorry.
No, you can go ahead, Lydia. Please do.
I was reading that we have another question from Jane. What's your best advice for working with individuals who are in this community? From being on the ground, I would say my best advice is to be very open to learning and to also be really comfortable with making mistakes, and just sort of saying, oops, my bad, how would you like to talk about this? And sort of asking questions out of a place of curiosity and also recognizing what you need to know versus what you want to know. So we're all curious, but make sure that that curiosity is coming from a place of how am I going to best support this person rather than just curiosity about what we might want to know about them and their identity and what they've been through. So understanding what you need to know versus what you want to know, as well as being comfortable with making mistakes. My best example of that is on forms. When folks ask for biological sex or sex assigned at birth, unless you're working in a clinical, like primary care or doctor's office setting, there's a good chance that I will never need to know that. I just need to know what pronouns and how to respect your gender identity at youth group.
Yeah, perfect example. Well, it looks like Kristen has a comment. She says, I find that creating an LGBTQI2S sensitive environment overlaps greatly with creating a trauma-sensitive environment. If we look at creating sensitive and safe environments that include capacities for both, the task will not appear as overwhelming. Awesome. That is a really some great input, Kristen. Did you guys have any thoughts that you wanted to add about creating safe space and how that can overlap with being trauma-informed?
Yeah, I think that the two go hand in hand, definitely, and it's really about making sure that people are supported and feel protected and safe, and that can open up the ways that people can talk about trauma and talk about the sort of the negative experiences that they've had, and as well as their ongoing needs, and so that is exactly what you would hope to be able to openly have discussions, even around misunderstandings, right, or even around prejudices or stereotypes or whatever topic of something to explore. And so if you're in a safe environment, then you can open that up, to feel comfortable enough to say, oh, I had this misunderstanding, and now can you educate me more on what I can learn more about, or or how things have how you've had those experiences, right? So this is the way that there can be a safe place to have those discussions. I think that's excellent.
I would also add that one way to create a safe space overlapping with that trauma-sensitive environment is to, if we're young adult peer leaders in our settings, or if we are staff, supervisors and directors of programs or services, that we are modeling and also holding our peers and staff to those expectations that Peter demonstrated in this webinar. Many times I've been into programs to sort of offer support to higher level staff or directors or managers around supporting LGBTQ youth, and they get it, but then when I observe on the floor, there's a sort of divide, a break between what the message is at the organizational level and then what is actually occurring day to day within that agency's culture. And so modeling and making sure that folks are held to an expectation that there is opportunity for growth and learning. But I find that modeling piece is really huge, particularly for young people and like our peers.
Definitely. Thank you for that input. And then if I was going to speak to the best way to work with young adults, or if I had some tidbit, one thing I feel like we didn't mention was it's important to not out people. If you're talking about someone who has disclosed to you that they are part of the LGBTQ community, that maybe other people don't know. So that you would be conscious of not making sure that you don't out them to people whether or not they are around. And another thing, I've been working as an LGBTQ advocate for more than 10 years, and I still learn new things every single day. So just because you have a lot of questions or you have gaps in knowledge, like, you shouldn't feel bad about that. There's there's always things to learn about the community. And so I would just encourage that if you do want to be competent in working with this population, that you just always continue to educate yourself about what's happening in the language changes, especially in things like that. Because even after working and being part of the community, I still learn new things every single day. So do we have any more questions from you guys before we close out for the day? And again, a reminder, we do have our survey for you there in the chat box. If you would just take a couple minutes of your time and feel free to click on that link, give us some of your feedback about the experience today. We would love to hear about it. So Peter or Lydia, do you have any closing thoughts that you would like to add today before we get out of here?
No, just thank you so much for
attending, and yeah.
And we're here for you.
Awesome. Yes, we've had a great turnout today. Thank you, everyone, for taking the time out of your day to join us and hear about this really important topic. Follow-up questions or concerns, please feel free to reach out to us. We'd be happy to talk to you on an individual level. We will also be sending you some resources and information that might be helpful to you in your own setting, in your community.